Hello and welcome to Health Styles. I'm Connie Mead. Most of us, if we have something to do in our everyday activities, we don't give it a second thought, we just go ahead and do it. But if you're someone who has heart disease and has been implanted with a cardiac defibrillator, you may think twice before jumping on a bike to take a bike ride, going on a vacation, going on a family hike, or dancing at a relative's wedding. So today we will take a look at implanted cardiac defibrillators and see how we can still enjoy a full life while living with one. Today my guest is Kathy LaFerriere, who is a cardiac nurse educator at Lowell General Hospital. I want to welcome you to the program, Kathy.
Thank you. Thanks for having me. Appreciate it.
Pleasure to have you here. Kathy also runs the ICD support group, which takes place quarterly at the hospital as well.
Right.
So, okay.
Yep.
Excellent. Well, so we have things to talk about here about heart disease and these devices that people might have, and most of us don't know anything about those, so this will be a great opportunity for you to educate us all.
That's great. That's why I'm here.
Okay. So first, let's just talk about heart disease a little bit.
Okay.
It's still a major killer in the United States, isn't it?
It is. It's still the #1 killer of both men and women here in the United States. And in fact, the older the population gets, especially with the women, more women will end up dying of heart disease than men.
Okay. All right. So who would you say is at risk for this?
Here in the United States, most of us, unfortunately, but certainly anybody who smokes is at a high risk for heart disease. If heart disease runs in the family, and we're talking at a young age, so if you had a parent, one or two parents who had a heart problem in their 40s or 50s, then that puts you at high risk, because then you think there's a genetic component. So you have to kind of watch what your parents do and what your siblings are doing, and if they're all falling to heart disease, then that's kind of a signal for you to get stuff going and start taking better care of yourself. Certainly if you have diabetes, that puts you at a big risk for heart disease. We know over 60% of people who have diabetes will have some form of cardiovascular disease, whether it's heart attack, stroke, or peripheral vascular disease, which is blocked arteries in the legs. So diabetes is a huge risk factor. And the problem here in the United States is with the obesity epidemic climbing, over 66% of the United States is overweight or obese. And with that number climbing, diabetes is more prevalent. And then, of course, if you have diabetes, puts you at risk for heart disease. So it's sort of this big vicious cycle that we're on right now. Okay. So diabetes, smoking, family history, those are three big ones. Other risk factors is high cholesterol, high blood pressure, and inactivity. And this one doesn't get enough play. People think because they might not be overweight, they don't really need to exercise. But being inactive puts you at risk for heart disease as well.
Okay.
So those seem to be the big ones.
All right. So that's when you're right. You don't hear that so often. So even if you have the ideal body mass index and all of that, you think you're doing just fine. You still, if you're not active, you're still putting yourself at risk. You're at risk. We know Jack LaLanne had it right so many years ago. We know when we exercise, a chemical is released into your body that actually helps relax your blood vessels, and it helps prevent heart disease from building, as well as keeps the weight down and keeps the blood pressure down, keeps the cholesterol down. So exercise is very important. What we tell people, 30 minutes every day. Like walk the dog 30 minutes every day, whether you have a dog or not. That's what all the cardiologists will tell their patients. So, and it's true. You know, obviously more is better, but if you can get 30 minutes in, that's great. And unfortunately, with technology today, you know, people are sitting in front of computers and the video games. Kids aren't getting out playing like they used to years ago. If kids aren't doing organized sports, they're not outside playing in the backyard like a lot of us used to be. And then we're afraid to walk anywhere. We don't let our children walk to schools anymore, and we don't walk to the store. You know, I know people who live less than a mile from the hospital, and they still get in their car. It's like we need to be more active. Right.
Just in the little daily things too. The tricks that you're taught. Park the car far from the mall. You know, make yourself walk. Don't look for that spot close to the mall. Take the stairs if you're only going up 2 flights of stairs, you know, instead of taking the elevator. So all these little these little tricks will actually help you become more active.
Okay, so we have to. There are some things that we can take control of and make little changes like that.
Absolutely.
Whether it's parking your car far away, taking the stairs,
Yeah.
getting those 30 minutes of exercise,
Yeah.
borrowing a dog if we have to.
Yeah.
So those are things that are within our control.
Right, and then the weight obviously is within our control.
Right.
Although we
So
seem
for
to
some
have lost
people, maybe
control.
not. Right. I mean, some people may have.
Some people it's harder, but it really comes down to calories in versus calories being spent. So you can blame metabolism, you can blame your family genetics because everybody's heavy, but the reality is that if you're taking in more calories than you're burning, you're going to put on weight or at least maintain. So if you want to lose weight, it's really a simple formula of burning more calories than you're taking in, and a lot of times it's as simple as just cut back a little ways. You know, people go on these dramatic diets and they don't last maybe a week or two, maybe a few months. Some people are lucky can stick to it, but then they don't stay with it. And so little tricks of, you know, if you go out on a Friday night and you have 3 pieces of pizza, well, try having 2 with a salad or 1.5 with a salad, you know, so you don't have to deprive yourself totally, but kind of little things like that you're taking in less calories and burning a few more, you will start losing the weight. And the biggest loser, I know those people that show those people have all those trainers, but that kind of proves that people who are 300 and 400 pounds can do it.
Okay.
It's a formula, calories in, calories out.
Okay. All right. So those are things within our control, and so we can each try to manage that part of our lifestyle. But there are people who will develop heart disease,
right,
or who have it now.
Yeah.
And certain ones of them need to have these defibrillators implanted.
Yeah.
So tell us, what is an ICD?
So an ICD stands for an Implantable Cardioverter Defibrillator. And what it is, it's a little device that's put in. We have one here.
Okay.
So this is the size of a defibrillator. And what is in here is a little computer as well as a battery. And then there's also the device that will, deliver the shocks. And so this is implanted right under the skin. And there's wires that come in here and they go right into the heart. And what happens is people who have weak hearts or maybe just some type of an arrhythmia, that the heart, instead of squeezing, it starts to quiver. And when the heart starts to quiver like this, the blood flow can't get to the brain, to the kidneys, to everything, and people get lightheaded and dizzy, and this is where they faint. What the defibrillator will do is when the heart starts to quiver, it will initially try to kind of race the heart out, so it'll try to kind of beat the heart rate to slow it down. If that doesn't work, then it will deliver a shock. And a lot of times people will feel the shocks. They might be lightheaded and dizzy. And it is painful. I've heard different things. It feels like you've been, kicked by a horse, or, it's pretty intense, but it's saving your life. Because once your heart starts quivering, if you don't get immediate attention, you die.
Okay.
And so these devices prevent sudden death, what we call sudden death.
Okay. Is that a heart attack, though? If somebody
someone can be having a heart attack. Once these are put in, it's usually because someone who's had a big heart attack and the heart muscle is very weak. We know when the heart muscle is very weak, you're very prone to these erratic heart rhythms.
I see.
So it can be someone who's had a heart attack. But unfortunately, children and adolescents also need these because they're born with these congenital abnormalities that set them up to have irregular heart rhythms. And you hear it all the time in the news, these young athletes. Seems to be more common with the athletes, that the heart will start to go erratic. And this is when they go down in sudden cardiac death. And so unless someone has a defibrillator on the field, a lot of these young athletes will die. So they come in, they have to have all these studies done if they survive the event, and then they'll put these devices in, and again, they'll save lives.
Okay, and this is something they'll probably live with their entire life?
Yes. Once they're in, they're in. And they do have to be changed every 5 to 7 years because the battery does wear down. And the wires will stay in place, but this can, we call it a can, will actually be removed. So the computer and the battery and everything, the whole thing is removed, and then just a new one is put right back under the skin.
I see. So is it a complicated surgery to have it done? It's not a full open heart surgery?
No, it's actually not even called a surgery. We just call it a procedure, believe it or not. It's actually a sterile procedure, so you go into a specialized room, and where everyone's gowned and gloved just like it would be in the operating room, because we don't want an infection.
Sure.
You get an infection in the heart, and that's a bad thing. So we treat it as a sterile procedure, and then the patient will be lightly sedated. So probably not as much as even a colonoscopy. You know, they're awake a little bit, but they don't seem to mind being there once we give them the sedation.
Sure.
And then like a local is given, it's called lidocaine, but it's very similar to Novocaine. So that numbs up the skin. They just put a tiny incision right here. It's usually on the left side, can be on the right. And then they put the wires in. The wires are probably about this long, and the wires thread through the vein that feeds into the heart. And you could have anywhere from 1 to 3 wires placed, actually sometimes even 4. And they're in different chambers of the heart. And then once the wires are in place, they attach them to the can right in there. And then that's slipped under the skin. They make a pocket under the skin, and they sew it up. And the patient goes home the next day. We usually just keep them for the night. And then they go home. And then the incision, you know, it's usually a week to heal. And usually they take it easy for a few weeks. Those wires need time to sort of implant in the heart wall so they don't move. So sort of the only restriction is like no really lifting the arm up. So no golfing or something. That's pretty tough on the guys, you know, for 6 weeks. But then after that, you can do anything they want to do. They're good to go.
Okay. So now, are you aware of those wires in your chest? I mean, do you feel them? Does it feel different?
No, they won't feel anything. Once the incision is healed up, they won't feel anything. They will feel the bump. You know,
so where it is.
You know, if there's a lot of tissue here, you're not going to feel the bump as much as someone who's very skinny up top. But yeah, it's just a tiny bump. Sometimes, you know, we have a hard time finding them when people come back in to have it replaced. We're feeling around because sometimes there's too much tissue there.
Okay. Now, you said something that I didn't quite catch. You said that that if somebody has a problem with their ventricles quivering, it's going to speed up the heart?
Yeah, because before the heart starts to quiver in a lot of cases, it's a ventricular arrhythmia, as they're called. So it is kind of squeezing initially, but it's not squeezing fully. So it's not giving a good squeeze like this. It's giving kind of a weak squeeze. So people who have that actually have a little bit more time before they get faint and lightheaded. And so there's a pacemaker in here as well. It's not just an ICD. The pacemaker will take over and will try to, what we say is outrun the rhythm. So whatever rhythm is faster wins. So if the pacemaker can outrun the body's rhythm, it can take control of it and then slow it down. And a lot of times patients don't even feel that that's happened. They'll come in for their routine check every 3 or 6 months, and then they'll check the device with the programmer, and they'll say, you know, your machine has worked maybe 3 or 4 times. It has taken you out of this life-threatening rhythm, and they didn't even know. So, but when unfortunately some people, they go right into more of the quivering, or the pacemaker can't control it fast enough, and then they start quivering. And once the heart's quivering, you go down. You know, you're not awake for that long when there's no blood flow, and you faint, and then, you know, the device will go off.
Okay, the device goes off, and it gives you a shock.
It will give you a shock.
The heart a shock.
Yep.
So that then puts it back into the right rhythm.
Right, it sinks it back into a normal rhythm. And a lot of times, if patients pass out, they wake right back up. And we tell people if it's only gone off once, you can call the doctor and let them know. You don't need to race to the emergency room. If it's gone off a couple of times, then we sort of suggest you go to the hospital. And certainly if it's repeatedly going off, you know, time and time again, then someone who's near you should be calling 911, and you should be getting yourself to the hospital.
Okay. So now, you also mentioned a pacemaker. Can you just tell us what the difference is between these two devices?
Yep. This one's actually a pacemaker. This one's actually it's much, much tinier. We've been putting these in for a long time, and the pacemaker is just going to control the rate. So inside our own hearts, we have our own internal pacemaker. It's called the SA node, and it tells the heart to send the impulses down the heart to make it beat. And unfortunately, the older we get, things just slow down and don't work as well as they used to. And so we put this pacemaker in people, and it will tell the heart to beat. And so when the heart rate gets slow, maybe 40 or 50, the pacemaker will kick in and keep the heart rate up into maybe the 60s or 70s. And young people, unfortunately, sometimes need this device as well if they're born again with some congenital abnormality. More, you know, we see it more in the older population. The older we get and things start to slow down. And we've put pacemakers in people in their 80s and 90-year-olds. Keeps them going a few more years, you know. Because once this is in, they feel great. You know, they come to the hospital feeling lousy. I'm just weak and tired all the time, and even fainting. We put this in, and they feel like $100 as we're wheeling them out of the room. They're like, I can't believe how much better I feel. So, yeah, and this is a day procedure as well. It's pretty much the same thing. The only difference with these, when we put these in, we do test these. So after this is inserted in the procedure room, we knock the patients out with not general anesthesia, but the anesthesiologist is there, and he'll totally knock them out, and then we test it. So we put them in that life-threatening arrhythmia to make sure it'll work.
Okay.
You
Okay.
know.
And then you also say you have to come back and have it checked every 3 to 6 months, but you're not removing it to do that checking.
No, they simply put this little wand, actually, it looks like a giant mouse, actually, you know, for the
Okay.
keyboard. They put
Computer
that right
mouse.
on, they put it right over the heart, and then they just look at their computer, and they can tell exactly what your heart's been doing since they saw you last.
Okay.
It's amazing. So for this one and this one. Once people are stable and they don't have any issues with it, they might not, see the doctor for every 6 months.
Okay.
Same with the pacemaker. And some of these devices you can actually check over the phone at home.
Okay.
They send them home with little kits so they can program themselves into the hospital or to the doctor's office.
Oh, all right.
Yeah.
So now what about activity? You mentioned, for the first few days you can't raise your arm, but then you said after a little while, everything will settle down, you'll be able to get back to your activity. So does that mean all activities? Or?
Well, with the ICDs especially, we kind of ask that no contact sports.
Okay.
You don't want to injure the device.
Mm-hmm.
But other than that, people can do what they want to do. A lot of people, especially the elderly who are very active, they go back to their dancing classes.
Okay.
They can go jogging, biking, whatever people like to do, they can do. Golfing is always, a big hit. There's really no restrictions after it's in. We used to worry about microwaves and things like that. We don't. The only thing that they do ask is that you stay away from magnets, big magnets, because a magnet will actually shut the device off.
Okay.
You don't want to shut it off.
Right. It'll probably interfere with the programming inside it.
Right.
And
Right.
all.
It totally shuts the defibrillator off if you put a magnet near.
Okay.
And we're not talking little refrigerator magnets. We're talking big, heavy duty magnets that in
industrial strength, sort of.
Right.
Okay.
Right.
Okay. Or maybe an MRI or something like that.
Yeah, you'd have to watch with the MRI as well. You have to let the doctors know before you have any of those type of procedures. In the operating room, obviously your doctor should know all this before they're operating on you, but actually in the operating room what they'll do is they will shut it off with the magnet and they'll put on an external pad.
I see.
Because they're using cautery and stuff, they don't want it activated at all. If it needs to go off, they'll have the external pads on you.
Okay, so they find a workaround.
They find a workaround.
Right.
Yeah.
But if you were just to take somebody to, say, an appointment, let's say, I'm a husband, I have the device, I have to take my wife for an MRI.
Yep.
So I go to the MRI office with her. Do I have to be aware that there's an MRI, say, in the next room? I might be in the waiting room. Do you have to be aware of that?
That's a good question.
Okay.
I don't know the answer to that.
Okay.
Actually.
Maybe you drop the person at the door and
Yeah,
let her go
and
in
leave.
by herself
Yeah, and
just
leave.
on the safe side.
Yeah.
Okay.
Yeah, I mean, like even walking through the, the stores.
Right.
Those,
right,
the
those
security
device
alarms.
devices, right.
I think there's some type of magnetic thing in there, but as long as you just walk through, you're fine. They just tell you don't hang around.
Okay.
And they've even had, studies where people are walking through very slowly with a walker, and they're still fine.
I see.
It's
Okay.
just,
Yeah.
don't hang out there. But you can certainly pass through a store, and then
Right.
obviously the airport and things like that. You're going to alarm all whistles, so you just tell them ahead of time, bring your card, and they'll just check it out.
Okay, so you do get a card, so that way if you travel, so traveling is not a problem.
No, just
because-
let everybody know. We tell people get to the airport a little bit sooner, because although actually everybody gets the pat down now, I guess these days.
Right,
So,
right. So
yeah.
you'd probably go into that line for the pat down
right.
rather than go through one of those
Right, because you're going to alarm
detectors.
it. You're just going to alarm it.
It's going to alarm it, and is it going to harm your defibrillator?
No, it's not going to harm the defibrillator. Right, it's just going to alarm it, so why bother?
Right.
Right.
Get everybody in a
Right,
tizzy. Okay.
exactly.
Right, okay. All right, and so then returning to activities, you say you can do whatever you want pretty much and at the same intensity that you used to?
Yeah,
It
actually, you're
doesn't slow
probably
you
going to
down.
feel better.
Okay.
No, you're probably actually,
okay.
once these devices go in, people are actually feel better, especially this one particular device we put in, and these are usually people who are pretty sick anyway, so they're not going to be out running any marathons anyway, but they actually have wires on both ventricles, the left and the right, and it gets the heart to sync together, so it kind of makes the heart a little stronger for people who
okay.
have heart failure, because this device is put in people who have significant heart failure. The heart is very weak, 15, 20%, and they're always back in the hospital in congestive heart failure. It's the most common reason people are admitted to the hospital. And so some of these people get these devices in, and it gives them a little bit more get up and go. But a little bit more than what they're used to. Again, not to the level that you and I are used to exercising.
Right.
And everybody is different for why they're getting these devices in. The condition of the heart is different to start with.
Okay.
Some of these devices go in very smoothly, and others are more complicated because patients might have very big heart or very scarred hearts, and we got to get those wires in a very good spot so they work the best using the least amount of electricity.
Okay. So is it becoming more common? It seems to me I've heard a number of people who have congestive heart failure, but I haven't heard that they've had this implanted. So maybe it's the particulars of their situation.
Yeah, this type where you have the leads on the both sides is kind of new, probably in the last 5 years.
I see.
And you have to meet a certain criteria to have it done. It's not just everyone with congestive heart failure. Some people have congestive heart failure and their hearts are not necessarily weakened in this type of state. A lot of people might have congestive heart failure because they've had high blood pressure untreated. It's called diastolic heart failure. And the heart's not necessarily weakened, it's just never getting a good chance to rest. It becomes a stiff heart.
I see.
And these are all reasons that people end up in the hospital.
Right, but it wouldn't help a person in that case.
No.
So it depends on the particulars
Yes.
of it. But again, now, is it more common for people to have these implanted, do you think, now? Or?
I think so. We've seen certainly a lot more up at Lowell General. We have Dr. Smith, he's the EP doctor, the electrophysiologist doctor, and he came to us from Leahy Clinic. And he's putting more and more in all the time. And I think because, unfortunately the baby boomers are getting older, and as we tend to age, we get sicker and more heart needs, and we're doing a much better job at keeping people going. So.
Okay. Well, let's just talk a minute about your support group too. Now, what does one have to do to be eligible to come to your support group?
Anybody can come. I mean, we obviously encourage anyone who has an ICD in. We want family members to come as well, because this is also impacts their lifestyle as well, and they're afraid. And that's the big thing for people with ICDs. They're afraid, especially when they first go in. The fears are, will it go off? Will it not go off? Will it go off correctly? Am I going to make it go off? We actually had one gentleman. He wanted it to go off. Because then he knew it was working. You know, and that's unusual. Most people don't want it to go off because they're afraid. But because of this fear, the problem is people aren't doing anything. And the whole point of putting these in, besides saving their life, is you still want them to have quality of life. You don't want people stuck at home watching the Wheel of Fortune every night and not doing anything. You want them to go out and be productive.
Right.
So we're trying to educate people with these support groups that you can do things. You can do whatever you need to do, and you want to educate the families to that point as well. It's a big psycho issue for people. It's scary, and family as well. So if we encourage anyone who has one, family members, and then anyone who maybe the doctor said, you know what, you may need an ICD down the road. Well, come on down.
Yeah.
And the one that we have coming up in June, we actually have a physician from East Carolina University, psychologist. He's done many, many studies on this. In fact, he's very well known nationally for this subject. So I'm trying to even get some of the nurses, anyone who deals with patients with ICDs, to come down and listen. He's a fabulous speaker. I heard him up at UMass Worcester a couple of years ago, and he had the room. He just wowed everybody. People in the audience were crying because I think they realized my life's not over. This is just the beginning, and it's just getting through those first few months of the fear and the unknown. But we want these people. Yeah, a big adjustment. Adjustment.
Yeah. So when does the groups meet? It
kind of depends. We tried to set it up quarterly, but it's probably more 3 a year is what we've been doing. And we try to come up with a different topic. So we've done one specifically on travel, and we had one of the patients come up and he talked his experiences getting through an airport. We did one on exercise, can you exercise? And then again, we had another gentleman get up and speak on his experiences. And sometimes people get up and talk. You don't have to. We call it a support group, and it scares people, but it's not that kumbaya, you don't have to talk. It's actually more, it's in the Clark Auditorium right at Lowell General, and it's catered by Lowell General, so it's a free dinner. And so first it's a dinner, and then followed by a lecture, and then we've had different physicians speak. And then if people want to get up and, talk about their experiences, they can, but if they just want to sit in their chair and just take it all in, they're welcome to do that as well. So
how do you find out when they're going to take place? Is it on your website? Or?
Yeah, it'll be on the website. There'll start to be more advertisement in the newspaper about it as well. And then what I've tried to do for the last year is I've actually sent out invites to all the patients that we've put these devices in at Lowell General, and that way they get a personal invite as well.
That's nice. Right. And so the one you have coming up is June
27th. We say 6 to 8. It might run a little bit longer. It kind of depends on how many people show up. But yeah, we're just so excited to have Dr. Sears. I really hope we can get a lot of people to come to this, because he really is, he's an amazing speaker, and I think people would get a lot out of it, people in the medical profession, families and patients as well.
Okay. And is it specific just to having these devices, or does he talk about heart disease?
He'll talk a little bit about heart disease, because most of the people who are getting these devices in is from heart disease. So they're already, when people get these devices in, they've already usually had a long course going. So he might even talk about that. And I know he does talk about that this generation of people getting ICDs, it's kind of new to everybody. You know, years ago when they put ICDs in, probably 20 years ago, those people didn't last that long anyway. They didn't do that well with them. They're very, very debilitating and painful. And now with technology and how far we've come, and you know, people are doing great with them. You know, so
let me just backtrack a bit here. If somebody does get the shock, I know we're getting back into what we were talking about a few minutes ago. You said it could be quite a jolt to them, and so then how long after that do they have to wait before they, you know, resume activity again? Do they
just
feel better?
Yeah, just till they start feeling well. There's actually on YouTube, it's a soccer player. If anyone's interested, I don't know what you would use, soccer player, I don't know, cardiac arrest. But they show him playing soccer, a young guy playing soccer. Now, I was surprised to see someone playing soccer, because he could hit in the chest.
Right,
when I was,
it's a contact sport.
So anyway, so he's playing soccer, and all of a sudden he drops. You see him fall right to the ground, and then you see him shocked, so you see his body shock, and then he sits right up, and right off the field he goes. You know, so he didn't go back into the game, but that just saved his life. You know, anywhere else that guy would have been dead. It's an amazing video to look at.
Yeah. Okay.
So,
all right. Wow, that's something to check out.
Yeah.
Another thing I want to ask you about is I noticed on the website, I went to the Lowell General website, and I looked under the departments, and I found cardiac, or I guess it was
the heart center.
Yeah. Heart center, right.
Yep.
And they said that you have free not quite free heart screenings.
Low cost.
Low cost heart screenings, but very minimal cost.
Yeah.
So can you tell us about that?
Yeah. I do most of them. They're once a month. Right now they're the second Monday of the month, because that seems to work best for my schedule.
Okay.
And they're $25, and it's about a 30-minute screening, and it includes a full cholesterol panel. So your total cholesterol, your good cholesterol, your bad, triglycerides, and a blood sugar, as well as a blood pressure. We'll do a body fat analysis and your BMI, your body mass index, so your height to your weight. We also do waist measurements, because waist measurements are so important now for heart disease. We know when you're carrying more weight in the belly, it sets you up for heart disease, and most people in the United States carry extra in the belly. Men especially, exclusively, when they put the extra weight on, it's in the belly. And we also will do an assessment of your pulses in your legs. And so if you need a further screening for that, we can do that. It's called an ABI, to see if you have decreased circulation to your legs. And then you'll have a nurse, usually myself, will discuss all the information, what the report means, and what you should do with the information. So it tells you whether you're at high risk, low risk, for developing a cardiovascular problem, meaning heart attack, stroke, or problems with the legs.
Okay, so for $25, that seems to be a very valuable consultation.
Yeah, we get a lot of people who don't have insurance, and just a concern that they, just want things checked out. So we'll get them, or we'll get people who they're taking very good care of themselves, and they would just want to be reaffirmed that everything is good, and that's fine as well.
Wow. Okay. Yeah. Well, that's great. So that's also on the website. They have to make an appointment for that.
Yes.
You have to register.
Yeah.
So
both of those you register either through the website or that LGH well number that you go through.
Okay.
And and same for the ICD support group. Just because it is a dinner, we're trying to get a head count and how much food to buy. Okay.
Well, great. Well, you've given us a lot of information, a lot of valuable information. I want to thank you for coming and for being here and sharing all that and educating us. So great, thank you for that, and the rest of us, I want to thank you for joining us as well, and I hope you will check out the ICD support group and also some of these free screenings, and also the lecture coming at the end of the month, June 27th. So thanks again, and join us